Good morning, ladies, gentlemen, and Mr. President. It gives me great honor to invite you to this joint session of the International British Urology Society and BAUS. IBUS has integrated well with BAUS, and we feel honored to be part of BAUS. I would like to thank Mark Speakman especially for his continued support. We have a panel of experts here who will be speaking on various topics. We'll have Dr. Curtis Nicholl, who's Professor of Urology, Queen's University in Ontario, Canada. He's a clinical researcher, a urologist, and is the international authority for inflammatory diseases of the urinary tract. He's going to update our knowledge on interstitial cystitis and bladder pain syndrome. This will be followed by Dr. Manoj Monga, who is Director of Stephen Stream Center for Endourology and Stone Diseases at the Cleveland Clinic. He's also the Secretary-elect of the AUA. Manoj has done a lot of work on medical therapy for nephrolithiasis, and he's an expert on stone management and ureteroscopy, and he's going to share his experience with us today. Dr. Percy Chibber is Director of Urology at the Jaslok Hospital, Mumbai, India. He has a long career in urology and did part of his training in Edinburgh with Professor Chisholm. He's pioneered the technique of percutaneous renal surgery in India and has one of the largest personal series of the procedure. He's going to talk to us on his experience of 30 years of PERC. He's also the current president of the Urological Society of India. And lastly, we'll have Randy Fagan, who's the Chief Administrative Officer at Texas Institute of Robotic Surgery in Austin, and is also Vice President, Robotics Hospital Corporation of America. He's held the position of Senior Medical Advisor for Intuitive Surgical and has performed over 300 Da Vinci prostatectomies. His current role includes the application of the largest database in the world on robotic-assisted surgery to improving quality of care, delivery, efficiency, staff training, and health economics. His talk will be on the economics of robotic surgery. So I'll invite Dr. Curtis Nicholl to give us his talk.
Thank you very much. I was very happy and pleased and honored to be invited to be one of the speakers at the joint IBUS-BAUS symposium, the last day of the BAUS meeting here in Manchester. And I get to talk about another topic that I really enjoy, related, of course, to male chronic prostatitis, chronic pelvic pain syndrome, but actually turns out to be very different. And that is bladder pain syndrome, interstitial cystitis, and today we're primarily going to talk about this in female patients. The disclosures, I again work with companies that are involved in research in bladder pain syndrome and interstitial cystitis. Who is this patient? The patient is, we all know her. She's the one with frequency, bothersome frequency, urgency, nocturia, maybe a history of urinary tract infections, but now the cultures are negative and antibiotics don't really work. Patient doesn't have incontinence. Sometimes the pain occurs as the bladder is filling and gets better with voiding, so it's perceived to be in the bladder. Patient may have other symptoms. She may have constipation, diarrhea, painful sexual intercourse, and aches and pains elsewhere outside the bladder, but sent to urologists because the pain is perceived to be in the bladder, and because of ruling out a diagnosis of exclusion, we call it interstitial cystitis. So what do we do? Well, traditionally, and maybe even yesterday when you saw this last patient, you rule out other conditions. Perhaps you do a cystoscopy to try and see if there's Hunner's lesions. Maybe you do a hydrostatic bladder dilation, see if there's glomerulations. Many times you just find a normal looking bladder. And what do? We treat the bladder as urologists do. Everything from inspirational talks that they don't have anything too serious, to pills that we give them based on very little evidence, to installations that we believe may or may not help them. We actually do surgery, and of course the urologic voodoo that we do with so many of diseases that we really don't know what causes them or how to help the patient. And then as soon as we can, we discharge the patient back to the family physician. That's been the traditional urology approach, and in North America, it has not worked out that well because the patients recycle to your partner or another urologist down the road. I got one main message in this short talk today, and that is when you see one of these patients, take off your urologic blinkers and look beyond the bladder. If there's no other message, that'll be the message. So, the way we look at this is the same way this morning. We're heading out this afternoon to go to the Lake District to do some hiking for several days. So I look at the weather maps to see what's going to happen over the next couple days. And the weather maps tell me a lot of information. They let me understand perhaps, and I say perhaps, what's going to happen to me when we're hiking in the Lake District. What it's going to tell me is perhaps, by looking at these maps, is the amount of precipitation, the type of precipitation, the temperature, sort of the quality of life that I am going to experience over the next 3 days. We have done the same pain mapping in hundreds of patients with bladder pain syndrome. Basically location of pain, but now using a computerized program, we're looking at the location of pain, the severity of pain, and the quality of pain in each of these areas. And we can see in a population of pain spectrums what's going on, and we can look, we've got a study we just started, over 600 patients, in which we're going to look at the changing spectrum of pain over a 3-year period. And what that's doing is helping us understand what's going on in the patient. So this is the composite picture of our patient with interstitial cystitis bladder pain syndrome in terms of pain mapping. And what we can see right now is that a lot of the pain is outside the urologic domain, that is the bladder or the pelvis. When we compare to controls, of course, there's going to be more pain in the IC-BPS patient, and you can see most of the pain, that red area, is lighting up in terms of the bladder, but there's pain elsewhere. This didn't help us very much because we know that IC-BPS patients have more pain, they have decreased quality of life, they have all sorts of problems compared to a normal population. Well, we've known that. So the pain mapping is of no really help in that respect. But what happens, our first study was looking at the number of pain sites reported, and we're able to pick out 4 very distinct different phenotypes. It turns out that 75% of patients, or 3 out of 4, have pain outside the bladder area. And depending on the number of pain sites, we're able to differentiate different phenotypes. This turned out to be a good research tool, but clinically it was not that helpful. So what we started to look at was, let's look at the pain syndromes outside the bladder. And we identified, as others have, that irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, vulvodynia, pelvic floor dysfunctional pain. All these are very associated in very high prevalence with IC bladder pain syndrome diagnosis, such that 40% of our patients who are referred to the urologist have IBS or IBS-like bothersome symptoms. Fibromyalgia, 1 out of 5. These are very prevalent conditions that we don't address as urologists. So we're able to divide our patients into 3 distinct categories, and it turns out that you can get about 20%, only 20%, 1 in 5 of our patients only have pain in the bladder, yet that's what we treat. So 80% of patients, I can predict we're going to have an unsuccessful outcome because we've ignored the pain outside the bladder. 40% have IC and IBS, where others have multiple. It's interesting, in the patients that we've seen, very few have interstitial cystitis and a systemic pain syndrome such as fibromyalgia. It appears to be a progression. We have the organ-specific pain, which is the bladder. We have the regional pain, and in this case it appears to be with IBS. Subsequently, we can also add vulvodynia and pelvic floor dysfunctional pain, or the chronic systemic pain, primarily fibromyalgia, but also chronic fatigue syndrome, everything from migraines to temporal mandibular joint disorder. And we see a phenotypic progression in the patients presented to urologists. In other words, those that only have IC, BPS related to the bladder, organ-specific, have a lesser duration of symptoms, while those that have an additional IBS have a greater duration of symptoms, and the ones with fibromyalgia have the longest. So we propose, and that's what we're looking at in our symptom pattern study that we just started, is over the next 3 years and over 600 patients, is to see if that progression actually occurs. But it does appear to occur in terms of symptoms, even in terms of IC, BPS-related pain, quality of life, coping, sexual dysfunction, anxiety, and stress. As you progress, the patient progresses from a bladder organ-specific to a regional pelvic pain syndrome to a systemic pain syndrome. Things start to fall apart. Now, we recently looked at pelvic pain only versus pelvic pain and beyond, because that's what the NIH is doing, and part of that process. It does simplify things in terms of biomarker research, in terms of what we're looking at now is phenotyping based on functional MRIs done over the years. We're comparing that to the microbiome of the bowel, bladder, and vagina, and we're trying to integrate all these with biomarkers and symptom patterns. The computer process to analyze this is going to be phenomenal. We have to use what's the term artificial intelligence, which is sort of a interesting concept in itself that I don't understand, but what you end up doing is plugging all this value in, and the computer tells you what is actually going on, I think. Because we haven't got that far yet, but we're collecting the data. But the pelvic pain only and the pelvic pain beyond is one way to look at it. So we've developed this model, and the model was developed on patients referred to our IC clinic, where patients come in with a primarily bladder-centric symptomatology, develop a regional pain symptomatology with vulvodynia, IBS, pelvic floor dysfunctional pain, and then eventually systemic pain syndrome. And that looked good until we started to put our IC nurse into the IBS clinic and found out the model was exactly opposite. Patient starts out with bowel symptoms, IBS symptoms, and over time develop bladder symptoms and systemic symptoms. And we're about to start with our rheumatologist looking at fibromyalgia, and I'm sure it's opposite. So, in fact, the organ specificity can start somewhere else, and the patient can progress. And that's why we end up with our silos. Whatever we start off with, we'll get a referral to a urologist, a gynecologist, a gastroenterologist, or a rheumatologist, because that's the pain syndrome we start with, and then it progresses into the other pain syndromes over time. 2 days ago, I presented the snowflake hypothesis is the way we approach patients with male chronic pelvic pain syndrome. And this has worked extremely well in our clinic. So several years ago, about 5 years ago, we said, let's see if this works in the females. Well, it doesn't quite work quite as well, but we are using it, and we're using the U-point in females as the best success we can. The problem is, of course, that everybody, by definition, has two of the domains, which they don't in the males. And that's everybody, by definition, has urinary domain with frequency, urgency, and nocturia, and everybody has organ specificity with pain perceived to be in the bladder. About a third have psychosocial correlates, infection, depending on using the history or concurrent infection, it's going to be between 8 and 30%. The neurogenic systemic, almost half of the patients have pain, other pain situations such as fibromyalgia, IBS, and tenderness. 50% of the patients have pelvic floor dysfunctional pain. So in understanding the pain phenotypes, we can continue to use the traditional urologic definition of interstitial cystitis, and I do. So I do a local cystoscopy, and in fact I have a 15-minute lecture on how to actually evaluate the patient using an anesthetic challenge test and define what's actually going on in the bladder without a general anesthetic. But by doing that, I rule out Hunner's lesions. Hunner's lesions, inflammatory lesions of the bladder, is a distinct disease. In my population, it's 12% of the patients that are referred to me. Those patients are treated differently. They have an organ-specific treatment or disease. They tend not to have IBS, fibromyalgia. They cope better. They're the real patients with real bladder disease, and we treat them as such. We can look at the number of pain sites, and that's turned out to be a wonderful research tool and absolutely no value in our clinic. Organ versus regional versus systemic has been very helpful because my nurse uses that. The patient has fibromyalgia, and we treat that particular patient with neuromodulation, amitriptyline, and the like. Patient has irritable bowel syndrome. We treat that with, depending on constipation or diarrhea, as well as the bowel and bladder-friendly diet. It's very important. Or we refer along to gastroenterology for an assessment. Pelvic pain only and pelvic pain and beyond is a concept that we're working with right now, and that's what we're going to be working on for the next 3 years, looking at biomarkers and functional MRIs and find out what actually is happening in this patient. We actually use U-point. My IC nurse likes U-point because once we know the pain is beyond the bladder, and that's 80% of the patients, we define the patient as pain in other organs such as vulvodynia, dysfunctional pelvic floor pain. Does she have an infection type of phenotype that we have to look at? Is there 1/3 of the patients need some sort of psychological counseling? So we do use U-point in that respect. So how does that help us manage this condition? Well, early diagnosis is the key. Every patient does have a bladder problem because they have urgency, frequency, and bladder pain. But we have to look beyond the bladder to other pelvic generators, the vagina, the bowel, the pelvic floor. If we don't manage those conditions or arrange for them to be managed, we can predict very poor outcomes and failure of our therapy. But we also have to look beyond the bladder to systemic pain generators in up to 30% of our patients. Fibromyalgia, back pain, migraine headaches, all the things, the aches and pains that impact on a patient's activities and quality of life. And we have to do this by identifying psychosocial parameters, sexual dysfunction. And again, we have a whole lecture on sexual dysfunction in IC, BPS, in how we actually manage that. Depression is something that we have the help of our psychologists. The catastrophizing, we talked about that with male, the rumination, the magnification, the helplessness has to be addressed through cognitive behavioral mindfulness therapy is what we use, including and maladaptive coping mechanisms, which is a wonderful topic, looking at pain contingent rest, being the couch potato, how they socially interact with others, and various things that help patients cope. Treat the patient. That's the important part with education, diet, and exercise. This is many patients, this is all that's required. Once a patient is educated what they have, they don't need pills or installations. They need education. They need to change their diet, which is so important. If the patient continues to drink coffee and eat chocolate, she's going to continue to have pain. A single cup of coffee on Monday is going to give her pain until Friday. It takes 2 weeks for the last cup of coffee to wear off in a bladder pain syndrome patient. So her telling you that she didn't have any coffee for 24 hours and her pain persisted, not good enough. And exercise, low impact exercise, stretching exercise, yoga, walking, swimming, elliptical, that sort of thing. Treat the bladder. We use the medications and intracycle treatments and surgery. And I wish I had time to go over my strategies for this, but I don't today. To treat the other identified pain generators that we've identified, whether it's a vagina with vulvodynia, we have treatments for that. Pelvic floor dysfunctional pain, the physiotherapists and muscle relaxants are fantastic. Fibromyalgia, we treat that now in our urology clinic rather than wait for the rheumatologist because we know exactly what they're going to do. The psychosocial factors, we even address those. We're sort of psycho-urologists or uropsychologists, whatever you want to call us, and we kind of help that, but we also use our pain psychologists. We avoid opioids. That's, again, another whole topic because this is a visceral pain syndrome. The best you're going to get is a 30% improvement with opioids. I can get a 29% improvement with placebo. So it's not going to help you that much. You're going to wipe out their endogenous opioids and they're not going to be able to manage. So what have we learned? We've learned to manage expectations, patients and physician. And in a condition where cure may not be possible, we set realistic goals. And those goals are based on the patient's clinical picture, clinical phenotype. We look beyond the bladder. And our goals are the amelioration of symptoms as best we can, not cure. Increase in life activities, and we try and pick something that the patient uses a goal, and improvement of the patient's general quality of life. Thank you very much, Mr. Chairman.